Greetings, fellow attendees at the NAACP annual convention. My name is Brian Smedley. I'm an equity scholar at the Urban Institute, and I'm really thrilled to speak with you today. One of the issues that, of course, remains urgent on our agenda is the need for health equity, the opportunity for people of color, African Americans, to achieve optimal health. And that includes addressing issues such as racism in our healthcare systems. This is one of the issues that I hope does not fall off of our critical agenda. We all know that it doesn't matter what your income or education level is, people of color, African Americans in particular, receive poorer treatment in our healthcare systems. Think of Serena Williams, a business mogul, world-renowned athlete who still got inferior treatment, poor quality care because her doctors didn't listen to her as she described a life-threatening medical condition that she experienced during her pregnancy. Think of the experience of the African American physician, Dr. Susan Moore, who passed away of complications due to COVID during the height of the COVID pandemic. She documented through social media platforms her experience interacting with her doctors who refused to believe her symptoms and didn't provide adequate care that she knew from her training as a physician was necessary to help preserve her life. So we know that it doesn't matter what your income level is or your educational attainment. For African Americans in particular, the issue of inferior treatment, poor quality treatment remains a persistent risk. I'm going to share some slides and talk a little bit about the issue of healthcare equity and where we may see some opportunities to advance an equity agenda that will hopefully help us to achieve what we call healthcare equity, which is simply everyone receiving the care that they need according to their need, not their financial circumstances, not their level of insurance, but according to need. So we've seen in recent years an exciting development, and that is that public health departments across the nation, whether in localities, states, or even our federal Centers for Disease Control and Prevention have called racism a public health crisis, recognizing that racism in all of its forms is damaging the health and well-being of African Americans and damages the very healthcare institutions that we have set up to attempt to deal with these problems. 20 years ago, I had the great honor of serving as study director for a report released by the then Institute of Medicine called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. This report was released in 2002 and really shocked the medical establishment with its assertion based on the evidence that racism is widespread throughout our healthcare systems. Now, we didn't use that word at the time, fearful that it would alienate key stakeholders. I wish we would have called racism and named it at that time, because racism is operating in many ways through our healthcare systems, how it's financed and paid for, the ways that our healthcare systems are regulated, and of course, the behavior of providers and clinicians in these systems. I'm going to touch on each of these issues, but first, let me just reflect back. In the 20 years since the publication of Unequal Treatment, we've seen very little progress toward narrowing and ultimately eliminating healthcare disparities. Our own Federal Agency for Healthcare Research and Quality finds that in particular for only 3% of measures for the African American population relative to the white population, are we actually eliminating those healthcare gaps. And you can see those same statistics again from the same Agency for Healthcare Research and Quality. If you look at the middle bar, you can see that African Americans relative to whites are still receiving worse care on nearly half of the quality measures that AHRQ uses in their National Healthcare Disparities Report. Why haven't we made more progress? I believe there are a number of factors that explain this. One, despite the weight of the evidence, we still don't have the political will for change. The status quo is really making some people very wealthy and happy, but we've got to challenge that status quo and insist that our healthcare systems be reimagined so that they address the needs of patients first. Second, we haven't had the tools and metrics to hold key stakeholders accountable for inaction to reduce inequities in care. One of the things I'm calling for example, is to publicly release data on healthcare access and quality metrics for healthcare systems, clinics, and hospitals around the country to allow us to really see where disparities and inequities occur. Third, and maybe most importantly, we haven't heard from the very people themselves who've experienced inequity in healthcare, who've experienced racism, who've experienced discrimination in healthcare. They have, in many cases, answers to help our healthcare be more patient-centric, focus on the needs and expectations and experiences of our patients. And finally, I think we've been siloed across the research, policy, and advocacy community. This is why I hope that in your work at the NAACP, that your national agenda can be assisted by organizations such as the Urban Institute, who can often provide the research and policy support so that we can together work toward advancing healthcare equity. There are a lot of reasons why healthcare inequity persists, including the fact that we still are treated in separate and inequitable healthcare systems. The fact that people of color are still concentrated in lower tier forms of health insurance and still disproportionately uninsured, despite the Affordable Care Act that President Obama signed into law. There is still evidence that clinician biases, stereotypes, and prejudice persist in ways that hurt patients of color and African Americans in particular. And on top of that, we have increasing use of race-based clinical decision supports and algorithms, often based on machine learning or so-called artificial intelligence. In some cases, these clinical decision supports can widen healthcare inequities rather than narrow them. And then finally, I'd argue we really have to tackle the lack of diversity among our healthcare professionals. Still to this day, African Americans are deeply underrepresented among physicians, as you can see from this pie chart, where the share of African American physicians on the left is represented in the white sliver. African Americans are only about 5% of US physicians, despite the fact that African Americans are 12% of the US population. We have to have a healthcare workforce that more closely reflects the US population in order to serve these populations' needs. To that end, another publication of the Institute of Medicine that I was very proud to be associated with called for things like changes in admissions approaches, whole file review, de-emphasizing standardized tests, which are poorly predictive of how well a medical school applicant will perform as a physician after they graduate from medical school. We have to attend to the institutional climate for diversity and include diversity efforts among our medical schools and nursing schools in the accreditation standards that they're being held to. And finally, those providers that want to serve in underserved communities should not have to pay a dime in tuition for their medical school or nursing school or dentist school costs, in my view. So we need to expand funding for programs like the US Public Health Service programs. But most importantly, we have to expand educational equity so that talented young people of color have the opportunity to get the training they need so that they too can participate in a health profession's career. There are a lot of state level levers for promoting equity in healthcare that we're exploring at the Urban Institute. I'm excited to explore these strategies with advocacy organizations, things like whether some states can still be persuaded to expand Medicaid, and even within that, Medicaid eligibility and coverage of populations of color, the generosity of state Medicaid reimbursement and benefits, mandated collection and public reporting of healthcare access and quality data by patient race, ethnicity, and primary language, as I mentioned earlier, I think can be an important tool to promote accountability. There are other strategies that I would love to explore with you all, but just want to offer these examples as a way of stimulating some conversation. Finally, let me conclude with a quote that I like from a renowned public health physician, Dr. Mary Bassett, who wrote in an article that we must name racism as a cause of poor health. She wrote, "Anti-racism is a collective healing without which our nation will remain painfully and inequitably divided, corroding opportunity, spirits, and bodies alike." I thank you so much for the opportunity to speak with you today, and I look forward to our continued engagement as we work together to advance health and healthcare equity.